SBS sir, good evening, sir.
Good evening, good evening.
Dr. Lakshmi?
Yes,
Sir,
sir.
good evening,
Shall we
sir.
start?
Yeah, madam has joined.
Yes, Janani ma'am is also here.
Okay.
The presenters are all here.
Good evening.
Oh.
Good evening, Sudhakar sir.
Sir, good evening, sir. Sir, SBS, sir, good evening,
Somasundram,
sir.
good evening.
Good evening, all of you.
Sir, good evening. SPS sir, good evening, sir.
Very good evening.
Janani
Good
madam,
evening.
good evening.
Good evening. Good
madam.
evening. Yeah.
Yes, madam.
Good evening.
Yes, madam. Yeah.
Good evening, sir.
Good evening, madam. Good evening.
Sir, madam, good evening, madam.
Good evening. Good evening.
Yeah. Lakshmi, you can start the program now.
Yes. Good evening, everybody. The IAP CCB Team 2026 is just so proud to present the first session of RUPE, Recent Updates in Pediatric Education. And words fail me because for one thing, I speak on behalf of the rest of the team. And when I say that we can't help but thank our stars for having SBS sir as the convener of this program. And of course, he's the teacher of teachers. And we also have mentors for each program who are seasoned academicians and stalwarts in their own way. We will have postgraduates presenting in these sessions. And how this was conceptualized, I think the best person to speak about this will be our president, Dr. Sudhakar sir, because this is his brainchild and we are all supporting him in this vision. Over to you, sir. Please talk to us about how RUPE came into being.
Yeah. Sir, good afternoon. Good evening to every one of you. I won't take much time actually. This is nothing but a continuation of our education in the Institute of Child Health and recent updates. We all have a lot of information gathered through the AI, Google, everything. We have plenty of information, but we don't know which is correct. So we need teachers like Dr. SPS sir, Janani madam, and many more people who can guide us what is the right actually. So there are a lot of guidelines will be keep on coming. As a student, we all may be, even though I'm a former professor, still I'm also feel I'm a student. So we need to know from our teachers what is the right guideline, how to interpret the guidelines, and how to make use in our clinical scenarios and our thing. So this is the right time for IAP CCP to start with our academic program and recent updates as the first program. And I invite Dr. Somasundram to give a felicitation for this program and a few words about it.
Thank you, respected SPS sir, Janani madam, Dr. Sudhakar, Dr. Lakshmi, and all the OB and EB of IAP CCB. It's proud that IAP CCB is initiating an good, a novel postgraduate educational program. So last year when I was the president, there was a parallel postgraduate teaching program with Dr. SPS sir as the convener in the name of Virtual Gurukulam, and one another program was running parallelly in Tamil Nadu as the PG teaching program. So at the time itself, Dr. Sudhakar sir told me that we will have a postgraduate program, but that will be different and it will not be the same lines as a PG teaching program. So it's a novel idea, sir. Definitely, such types of the updates in pediatric education will be definitely needed for these postgraduates because things are ever changing. As you told, definitely this will be useful for the postgraduate. I wish all the program a great success. Thank you very much. Yeah.
Thank you, Dr. Sumar. Dr. Janani madam, she's our mentor for this program. Madam, the stage is to you. You can start the program, madam.
Yeah. So, good evening, everyone. And thanks to Sudhakar for the opportunity. And I think the session is, the convener is Dr. SBS, and we're all lucky to have him. And as per Sir's suggestion, the first the RUPE session, we are having hemophagocytic lymphohistiocytis, the current updates and in the diagnostic criteria, manifestations and management that will be discussed by 4 postgraduates. I think Lakshmi can introduce the postgraduates, and after SBS says a few words, we can start. So the postgraduates have done a real good job, and Lakshmi has taken efforts to compile all the presentations. And we just thought Each of them will present for around 8 to 10 minutes, and the total of 40 minutes, and then the last 20 minutes, 15 to 20 minutes will be discussion and final take-home points from Dr. SBS. That was the plan, and Lakshmi, probably you can introduce the speakers after Dr. SBS says a few words.
Thank you, Dr. Janani.
Sure, ma'am. Over to SBS, sir.
Yeah, thank you, Dr. Janani. In fact, the idea of starting this is that of Dr. Sudhakar. He was very keen to do something exclusively different for the postgraduates. And he initially thought we should create an e-library for the sake of students by Chennai CCB. And we realized the logistics will not be that easy to implement. And Dr. Lakshmi Prashant and Sudhakar came out with this brilliant idea of taking up one topic. I guess it's every month. Am I right, Dr. Sudhakar?
Yes, sir. Yes, sir.
So
Once a month.
that means we will be able to do 11 topics this year. And I suggested that you can take up one topic of relevance where we will look at recent developments. And the first topic that came to my mind was none other than hemophagocytic lymphohistiocytosis. And Dr. Sudhakar immediately thought of Dr. Janani, and I readily agreed that she is the best person to be the mentor for this session, and we are honored. In addition to the postgraduates, Dr. Janani, me, and taking part today, I have a surprise today. At the end of the program, Professor A.V. Ramanan, the pediatric neurologist, the rheumatologist from Bristol, UK, and our close friend, he will be joining toward the end of the session. And I requested him to spend about 15 minutes because he'll be sitting in his OP today in Bristol. And he agreed. I will call him at around 40 minutes from now, and he will join. And I'm going to have a 10-minute dialogue with him, provoking him with difficult questions. And that will be an icing on the cake for today's program. Okay,
Great.
Over to Dr. Janani. Is that
Yeah,
all,
I think,
Dr.
yeah,
Sudhakar?
yeah.
Thank
Is
you,
that
sir.
all right?
Yes, sir. Yes, sir. Really, we are excited.
Subject to your approval.
We are excited to have, sir.
Okay,
Yeah.
thank you. Thank you. Don't worry.
So that makes it complete.
Yeah.
Lakshmi, you can introduce and we can start.
Yes, ma'am. Sure, sure. My pranams to the teachers here. So today our presentation is going to be in a structured format as we move from, the etiology, clinical features, diagnostics, and finally the management. And we have with us 4 budding stars. We have Dr. Darshini K from ICHN Hospital for Children, Chennai. We have Dr. Maheshwari P from Child's Trust, Chennai. Dr. Shobila from the Institute of Child Health, Madurai. And Dr. Srinidhi from MKV Pondicherry. So without further ado, I think let's just move on to the presentations. The first of which, let me introduce Dr. Maheshwari. Yes. So she will first start off on etiology of HLH. Dr. Maheshwari, you can start presenting. I will move through your slides.
Okay, ma'am. Thank you, ma'am. Good evening, everyone. Today, I will be discussing the etiology of hemophagocytic lymphohistiocytosis. The understanding etiology is important because early identification of underlying cause directly influences the management, prognosis, and genetic counseling. So, introduction, HLH is a severe hyperinflammatory syndrome that can be rapidly progressive and life-threatening. It is characterized by uncontrolled immune activation. The condition was first described in 1952 as a familial hemocytic reticulosis, which we now recognize as the inherited form of HLH. Next slide, ma'am. So
next, yeah.
So let's see the history of HLH. This timeline reflects how our understanding of HLH has evolved over nearly 9 decades. The earliest description dates back to 1939. When Scott and Rob Smith described a fatal inflammatory disorder termed histiocytic medullary reticulosis in adults. In 1952 only, the familial form of HLH was identified, which is termed as familial hemophagocytic reticulosis. Then during 1970s and 80s, the disease was further conceptualized, recognizing that the acquired form like virus-associated hemophagocytic syndrome. At the same time, there is impaired NK natural killer cell cytotoxicity was identified as the key immunologic hallmark. Then in 1990s, the first international diagnostic guidelines were published in 1991. In 1992, the current term, the hemophagocytic lymphohistiocytosis, was coined. And in 1994, the HLH-94 protocol standardized therapy dramatically improved the survival. Then in 1999, the first genetic defect in perforin gene was identified. And in 2000, so the additional genes like UNC13D, STX11 were identified. Then in 2004, the revised diagnostic criteria of HLH guidelines were released. Later, the further next generation sequencing further accelerated genetic diagnosis. In 2018, emapalumab, the targeting interferon gamma, was approved for primary HLH. So importantly, now the between 2023-2025, there has been conceptual shift towards understanding of HLH as a continuum rather than binary disorder. In latest in 2024, the recent updated diagnostic guidelines were released. So this is the timeline. Next slide.
Just a second, just a second, just a second.
So, traditionally, HLH has been defined, has been classified into primary HLH and secondary HLH. Primary HLH is are referred to cases caused by pathogenic gene variants that predispose patients by variety of mechanisms, mainly that affecting natural killer cells and cytotoxic T lymphocytes. Secondary HLH occurs in settings of external triggers such as severe infections, malignancy, or rheumatologic diseases, which results in intense immune activation. However, this classification is increasingly being reconsidered, about which I will discuss later in the slides. So, coming to pathogenesis, first, the main four things are: first is defective cytotoxic function. So, normally, natural killer cells and CD8 positive T cells eliminate infected or activated target cells through perforin gram-same pathway. So in HS, due to genetic defects involving this, the cytotoxic killing is impaired. And second is because the infected or activated antigen presenting cells are not clear, there is persistent immune activation. And third is there is macrophage overactivation, which leads to hemophagocytosis, and which leads to cytopenia and organ infiltration. And the fourth one is cytokine storm, which leads to excessive release of interferon gamma. This is responsible for systemic manifestations and multi-organ dysfunction. So fundamentally, it is a disorder of failure to terminate the immune responses, leading to uncontrolled inflammation. Next slide. So moving on to the primary HLH, or genetic cause of HLH. The primary the conditions where the HLH is the predominant manifestation are termed as primary HLH. So we have four groups. In this, first is familial HLH. We have 5 types in this, and these are the genes involved. So all these genes are involved in perforin granular exocytosis pathway. So and then there's a pigmented disorder associated with HLH, like Griscelli syndrome, Chidiac-Crafty syndrome, Hermansky-Butlak syndrome. In these disorders also, there is a defective lymphocyte granule mediated cytotoxicity. And we have X-linked lymphoproliferative syndromes caused by mutations in SS2D1A and XAP. So these due to the defect in the inflammasome function. So more recently, the newer genes like NLRC4 and CDC42 have been identified. So these are also associated with inflammasome dysregulation. And EBV next slide. So then the fourth group is EBV susceptibility disorders. So certain genetic defects predispose patients specifically to severe uncontrolled EBV infection, which then triggers HLH. So these are the mutations involved in this EBV susceptibility disorders. So these are primary HLH or genetic cause of HLH. Next slide, ma'am. So this slide shows the primary immunodeficiencies and inborn errors of metabolism that are complicated by HLH. So among primary immunodeficiencies, HLH was well described in conditions like severe combined immunodeficiency, Wiskott-Aldrich syndrome, X-linked agammaglobulinemia, and another is our inborn errors of metabolism like lysosomal protein intolerance have been associated with HLH-like presentations. In these metabolic conditions, the immune activation is mainly driven by chronic inflammation or macrophage activation. Next slide, ma'am. Secondary HLH occurs when there is intense immune activation is triggered by underlying condition. So the most common etiology is infections. Among viral causes, EBV is the commonest, and other but CME, herpes simplex virus, HIV are also implicated. Bacterial infections like tuberculosis, parasitic like leishmania, malaria, fungal histoplasma are also implicated. Any infection, any malignancy can trigger HLH. The second major category is malignancy, so of which particularly this T-cell and NK cell lymphomas, leukemias are most common, and post-transplant lymphoproliferative disorders. Third is rheumatologic or immune dysregulation disorders. So the HLS associated with systemic juvenile idiopathic arthritis is known as macrophage activation syndrome. This also occurs in SLE, Kawasaki disease, autoinflammatory syndromes. And other drugs and iatrogenic causes such as immune checkpoint inhibitors, chemotherapy, post-hematopoietic stem cell transplant also trigger HLH. And other metabolic and severe inflammatory states also trigger HLH. Next slide, ma'am. So now why the classification changes. Both primary and secondary can be triggered by infections or other immune activating agents. Conversely, pathogenic gene variants can be found in individuals of any age and with any family history. So identifying pathogenic gene variants is important for accurate diagnosis, prognosis, and individualized treatment. So what is the modern concept of HLH etiology? It is not strictly primary versus secondary. Now it is threshold disease concept. That is when combining genetic susceptibility and trigger, when it is crossing critical tipping point, it will lead to HLH. This explains late onset and overlap syndromes. So hence etiological evaluation should proceed in parallel with the treatment. So this one ties beautifully into later diagnostic and management slides. So in genetic susceptibility, classic cytotoxic pathway defect remains central. However, we recognize that not all patients have complete loss of function mutations. Many individuals have hypomorphic or heterozygous variants, and polygenic and digenic inheritance also the further lower the threshold for the disease. So the environmental side, triggers are broadly classified as immune activation, immune deficiencies. These infections, malignancy, lymphatic disorders are they cause immune activation. The other immune therapies they cause immune deficiency. These act as environmental triggers. So when these combine and it crosses when it crosses the threshold, it lead to HLH. So recap: HLH is hyperinflammatory syndrome, representing final common pathway of immune dysregulation. Etiology is best explained by threshold model, where genetic susceptibility plus the immune trigger lead to disease. Genetic defects mainly involve impaired NK cell and cytotoxic T cell function, with hypomorphic mutations causing late presentation. Infections, especially EBV, are the common triggers of unmasked underlying genetic HLH. So identifying etiology and trigger is crucial as it directly influences treatment intensity and need for hematopoietic stem cell transplantation. Thank you.
Thank you so much, Doctor. So next, may I invite Dr. Darshini? She will now take over and present the clinical features of HLH.
Yes, ma'am. Shall I start, ma'am?
Yes, please.
Yes. Good evening, everyone. I am Dr. Dashni K, PG resident from ICH Egmore. My topic is about the clinical features of hemophagocytic lymphohistiocytosis. So, basically, as my previous speaker said, HLH is a life-threatening hyperinflammatory syndrome, which is due to immune dysregulation. The primary, which is the familial HLH, and the secondary HLH are clinically indistinguishable, and hemophagocytosis is not specific for HLH. So the clinical diagnosis relies on patterns and not a single finding. Coming to the age, next slide. Coming to the age and pattern of presentation, so the primary HLH typically presents in infancy, usually less than 2 years of age. The secondary HLH is more common in older children and adults. Either form can present at any age group. The secondary HLH may unmask an underlying genetic effect. Over 1 year period, ICH has recorded over 47 admissions, out of which 11 cases, accounting for 23%, were found to be primary HLH. Some history-wise clues to differentiate between primary and secondary HLH is the age of onset. In primary HLH, the age of onset is usually infancy or early childhood, whereas in secondary HLH, it is in older children and adolescents. Family history is more often associated with primary HLH with a history of consanguinity, which is absent in secondary HLH. The triggers are usually mild or none in primary HLH, whereas in secondary HLH, you will have a clear trigger like infections, malignancies, or rheumatological factors. The CNS disease is more often early, prominent, and isolated in primary HLH, whereas in secondary HLH, they appear later. The relapse risk is also very high in primary HLH compared to secondary HLH, and the course is progressive in case of primary HLH, whereas in secondary HLH, it is trigger dependent. Coming to the clinical clues for primary HLH, so the Griscelli syndrome may present with silver gray hair and hypopigmentation, whereas Chediak Higashi can present with albinism with recurrent infections. X-linked lymphoproliferative disorders can usually occurs in male with a EBV trigger. Familial HLH occurs in infants with a history of consanguinity. ALPS, the patients will usually have a chronic lymphadenopathy, and MAS, you will have a rheumatological disease flare-up. This is a child which has been admitted in ICH with Chediak Higashi syndrome. Next, coming to the systemic clinical features. So you will have a persistent high-grade fever, which is more than 101.3 degree Fahrenheit, which is due to the cytokine storm. And the cytokines involved are interleukin-1, 6, TNF-alpha, and interferon gamma. Next is your hepatosplenomegaly, which is pronounced and progressive. So this is basically because of the immune cell infiltration and can also be due to inflammation per se. Then lymphadenopathy is seen in about 20 to 50% of the cases. This is also due to the hemophagocytes, which go and reside in the lymph nodes and cause reactive hyperplasia, or per se the immune activation also. The other features include weight loss, irritability, failure to thrive, and the rash in HLH will be usually intermittent, waxing and waning type of rash. Coming to the other rare features, so you can have other system involvement like your hepatic system presenting with jaundice, coagulopathy, and ascites. Hematologically, you can have pallor and bleeding. Pulmonary features include ARDS, respiratory failure. Cardiac features include myocarditis, arrhythmias, etc. Renal features include AKI. And GI, you can have chronic diarrhea. So the basis for all this involvement is your immune dysregulation leading to cytokine mediated injury and which affects your each and every organ system. The next is the newer one, which is your neurological involvement in the HLH. So the neurological involvement is basically because of infiltration of the activated T cells and the macrophages. They lead to cytokine-mediated neuronal injury, causing demyelination and cerebral edema. So this occurs in about 50% of the patients. They can present with seizures, headache, altered mental status, ataxia, focal neurological deficits. And this pie chart just shows the different clinical features and their percentage manifestations. The next is the imaging and CSF. So imaging is usually MRI is preferred. The MRI shows diffuse or multifocal T2 or flare hyperintensities, and there will be involvement of gray and white matter. CSF shows pleocytosis, elevated CSF pressure, and increased ICP with the macrophages similar to marrow findings. Sometimes you can also have an isolated CNS HLH. So you here there will be lack of cytopenia, splenomegaly, or systemic inflammation initially. The neuroinflammation usually precedes your HLH by years. 35% will eventually develop your systemic features. The main defect in isolated CNS HLH is that it is often misdiagnosed as ADEM or encephalitis. This pie chart just shows you the CNS biopsy findings in HLH and MRI findings. So the biopsy findings include lymphohistiocytic infiltrates, which accounts for 63%. The others include microinfarct, hemorrhage, granulomas, and necrosis. MRI finding includes diffuse multifocal white matter lesions, cerebellar involvement, periventricular changes, and brainstem involvement. The final picture is just a deception to show the triggers, which are nothing but your medications, malignancies, autoimmune diseases, infections, which ultimately leads to your immune dysregulation in the form of hypercytokinemia, hyperferritinemia, leading to hemophagocytosis, causing all the organ system involvement. So the key clinical takeaway is that HLH is a multi-system inflammatory syndrome with protein manifestations. Clinical features alone cannot distinguish primary from secondary. Neurological involvement is common and may be isolated. High clinical suspicion is essential to avoid delayed diagnosis. Thank you.
Thank you so much, Doctor. Let's quickly jump on to our next section, the diagnostics in HLH, and inviting Dr. Srinidhi, alias Dr. Amrita. Please take over.
Good evening. Thank you, ma'am. Today we'll see the diagnostics of HLH. So HLH is not a single disease. It is a spectrum of disease. The core of HLH spectrum is that HLH disease which fits into the diagnostic criteria of HLH, and the periphery is formed by the HLH disease mimics which doesn't fit into the diagnostic criteria of HLH. And there are 5 subsets which includes familial HLH, which has a genetic cause, and rheumatologic HLH, which is associated with conditions like SLE, SOGIA, etc., and malignancy associated HLH, which is associated with Hodgkin's lymphoma, etc., and HLH with immune compromise, that is associated with primary immunodeficiency, and iatrogenic HLH, which is secondary to immunotherapy. And if it doesn't fit into any of these criteria, then we can call it HLH not otherwise specified. And next slide, ma'am. So, according to Nelson, the diagnostic criteria of HLH fits into Tier 1, and Tier 2 forms the genetic causes, evaluation for the genetic cause. So, the diagnostic criteria for HLH is molecular diagnosis consistent with HLH and fulfillment of 5 of the following 8 criteria. First is fever, temperature more than 38.5 degrees Celsius for more than 7 days, and splenomegaly with spleen tip palpable more than 3 centimeters below the left costal margin, and cytopenia involving 2 or more cell lines, hemoglobin less than 9, platelet less than 1 lakh, and absolute neutrophil count less than 1000, and hypertriglyceridemia or hypofibrinogenemia, and hemophagocytosis in bone marrow, spleen, or lymph nodes, low or absent natural killer cell activity, serum ferritin more than 500 micrograms per liter, and soluble CD25 interleukin 2 receptor, that is a direct indicator of T cell activation, which is more than 2400 units per ml. Next slide, ma'am. So the Tier 2 investigations is we are evaluating the genetic causes for HLH. If a child is suspected to have HLH, first we'll find out whether the child is, if it is a male child, we'll try to find out whether it fits into X-linked type 1 or type 2 HLH. If it is type 1, there is SAP deficiency, which is nothing but signaling lymphocytic activation molecule associated protein. It can be associated with lymphoma or EBV infection. Type 2 is XLAP, which is nothing but X-linked inhibitor of apoptotic protein, which is associated with splenomegaly and colitis. Then the next step would be to do flow cytometric assays. If perforin is defective, then it comes under familial HLH type 2. And if granule release is defective, then it comes under familial HLH type 3, for which we will do Western blotting. And if it is type 4, there will be signaling defect. And there will be syntaxin 11 defect in Western blotting. Familial HLH type 5 is nothing but type 4. Along with it, colitis and hypogamma globulinemia will be there. And if it doesn't fit into any of these criteria, then we can consider it as familial HLH type 1. So, if there are some syndromic associations with HLH, if there is albinism, then we'll do blood smear and hair analysis. So, if there are giant lysosomes and leukocytes, and there is evenly and regular distributed melanin, then it comes under Chediak-Higashi syndrome. And in Griscelli syndrome type 2, there is irregular melanin, and under polarized microscopy, hair appears monotonously white. And in Hermansky-Pudlak syndrome type 2, there is increased bleeding and neutropenia. Next slide. So this is the new revised criteria for HLH according to Euler Society. It is CNS dysfunction has been recently included in this. Encephalitis, encephalopathy, altered mental status, seizures, CSF pleocytosis, elevated CSF protein, and increased ICP on LP, and radiological evidence of inflammation on MRI. And in DIC, previously there was low fibrinogen. Now they have included increased D dimer, prolonged PT-INR, and APTT. Next slide. This already has been discussed that this is the neurological involvement of HLH where we can see hyperintensities in the white matter. There can also be involvement of the gray matter, and cerebellar involvement can also be there. Supratentorial and infratentorial regions may be affected. And the next slide is explains the rationale for doing these investigations. In CPC, there is cytopenia of involving two cell lines. This is because marrow is involved and sequestration and consumption happens in the marrow. Inflammatory biomarkers are elevated. CRP is elevated in response to interleukin 6, and ferritin is elevated due to hepatocyte activation, and ESR is reduced due to the fibrinogen consumption, and LDH is elevated due to cell death or injury, and interleukin 2 receptor alpha, this directly indicates the T cell activation. This is otherwise called as the CD25. And CXCL9, this is a sensitive and a specific indicator of interferon gamma signaling pathway, and interleukin 18 is elevated due to inflammasome activation. And in LFT, AST, ALT are elevated due to hepatocyte injury, and triglycerides are elevated due to cytokine inhibition of lipoprotein lipase. Albumin is lost due to the leak into the third space or vascular leak. Then coagulopathy, there is fibrinogen conversion to fibrin, so there is hypofibrinogenemia, and D dimer and PT-INR are elevated. And already we have seen that MRI and CSF findings are abnormal due to the inflammation of gray and white matter. So this till this whatever we have seen is the tier 2 investigations. That is first one is fitting into the diagnostic criteria, and tier 2 will be evaluating for the genetic cause. The tier 3, this is the newer addition, which is identification of the trigger. Previously, HLH was classified as primary and secondary. Primary, which has a specific genetic or familial cause, and secondary was due to some trigger, infection, bacterial or viral. There can be some autoimmune associations or malignancy associations, or it can be undetermined. But now what they have found is every person who fits into the diagnostic criteria of HLH must undergo a genetic testing to find out their genetic susceptibility. And the next thing is that there should be a trigger identification, whether it can be due to any infection associated or any predisposing factors like any autoimmune or malignancy associations can be there. And the fourth tier will include the involvement of CNS, because CNS involvement will decide the prognosis of the disease and the management. Next slide now. So if HLH is suspected, we will do the primary line of investigations. We'll see the primary line in next slide. And then if HLH is likely, then the first thing we should do is rapid screening test for genetic associations, which is nothing but perforin, SAP, XLAP, and natural killer cytotoxicity and hair analysis. And the next step would be to identify the triggers, whether it is viral, then we can do viral PCR. And if we are suspecting malignancy, we can go for CT, PET, and then rheumatologic. Accordingly, we can evaluate for the specific disease. And then the next step would be to monitor the progression of HLH with the basic parameters, and the frequency and what is to be done we'll discuss in the next slide. This is the updated diagnostic strategy of HLH. Here, if there is any unexplained cytopenia or hepatitis or inflammatory CNS disease, if it is present and there is unexplained fever in history, and on examination, if there is hepatosplenomegaly, and in past medical history, there is previous HLH-like episode, and in family history, there is any history of HLH in the family, we will do the inflammatory markers, serum ferritin and SCD25. And if it is elevated, we will do the first line investigations, that is CBC, fibrinogen, triglycerides, ALT. And the second line investigations will include the primary genetic rapid screening test, which is perforin, SAP, X-linked AP protein. And next would be the tier 3 investigations, which are supportive, like CT, viral PCRs, etc. And if it is positive, we'll go for confirmatory genetic testing, which is nothing but whole genome exome sequencing, and CNS workup, which is LP, MRI brain. And we will follow it up with CBC, ALT, and fibrinogen initially on daily basis, and weekly SCD25 and serum ferritin. If all these doesn't fit into if we couldn't identify the trigger, then we will go for immunodeficiency workup and malignancy workup. This is the 4-tier investigation. And here we have the first diagnostic criteria of HLH, and the second tier would be to do the genetic workup, and the third tier will be to do the identification of trigger, and the fourth tier will be to do the CNS, finding out the CNS etiology. Next slide. No? So to conclude, we have identified that HLH is not a specific disease. It is a spectrum of disorder, and we have moved from 2-tier investigation to a 4-tier investigation system, where trigger identification, neuroimaging, and CSF analysis is the new addition. Thank you.
Thank you very much. Let's move on to the final segment of today's presentation, management of HLH. May I request Dr. Shobila to start the presentation?
Good evening, everyone. I'm here to talk about the management of the HLH. As we know, HLH is a rapidly progressive, life-threatening hyperinflammatory syndrome. The management is aimed at tempering down this hyperinflammatory state. This management of HLH comprises of many components.
It's echoing, ma.
And
Lakshmi, it's echoing. I think she's joined from 2 devices. Huh?
Shobila, your voice is echoing. Have you joined from your laptop or your phone? Can you just check your audio?
2 devices means ask her to mute one.
ma'am, am I audible now, ma'am?
Yeah.
Yeah, you are audible.
Yeah, you can carry on. Yeah.
Okay. First, we need to do initial baseline assessment and investigations for etiological workup. Then we will go up on initial.
Please mute the others, no, please.
Initial
yeah, you carry on.
Administration of empirical immunomodulator therapy, then context-specific treatment after the etiology is identified, and at last hematopoietic stem cell transplantation based on the need. Next slide. Here we first move on to the pre-treatment testing. Before initiating the treatment for HLH, there are certain disease markers. We have to do baseline immunological studies and the serum markers, serum ferritin, CBC, fibrinogen, and D-dimer, because they help us in monitoring the disease response to the therapy. Then baseline cardiac evaluation and HLA typing and search for an HCC donor in suspected inherited mutations. After the pre-treatment testing with ongoing
Hey,
investigation.
Lakshmi, can you mute the person who's talking in between, please?
Everybody is actually on mute. So, I
I
mean,
don't know who's
yeah,
talking.
I
in
just
between.
checked. Everybody is on mute. So I don't know if Dr. Shobila, you are not logged on from 2 devices, right?
Maybe that is the one reason.
Maybe it's just echoing from her own, because everybody is on mute, ma'am. You have just muted all.
Now it is clear, ma'am?
Yeah, okay.
Mm.
Remove, if you've dropped from 2 devices, please mute
No,
one
no,
device.
no.
But it looks very, echoing your voice. Okay, go ahead.
The initial management for the HLH consists of a supportive care. Supportive care includes antipyretics, fluid management, and blood products in case of anemia, thrombocytopenia, or BAC, and nutrition and BP control. Prophylaxis includes pneumocystis zero prophylaxis and antifungal prophylaxis, and empirical antimicrobial therapy is needed if the cause of the infection
The voice is echoing, still not clear.
Not clear at all, yeah. You close your video and talk. Maybe you can check again whether you've logged in from 2 devices.
Yeah, most probably 2 devices, iPad, laptop or something.
Laptop and mobile. Kindly mute one, please. Someone says she's in a closed room. Open the door then. Yeah, continue, doctor. Let's see how it is now. She can continue, no?
Yeah, yes, doctor. Dr. Shobila, please continue.
Ma'am. Yes, ma'am. Yes, sir.
And the
Slides, ma'am. Slides, ma'am.
Lakshmi slides are not seen, Lakshmi. Lakshmi is not there. Huh? What's happened?
Madam, she got disconnected. She'll be joining back in few seconds.
Okay. Good evening, Ramanan sir. Joined. Yeah.
Good evening.
Sir, good evening, sir. Thank you so much for coming here to attend our program and we're going to give your inputs. We have to thank Dr. SBS sir for inviting you and bringing you here, sir. It's a great pleasure to see you.
Thank you.
Now, so Lakshmi is joining or not?
No, she says she'll be joining.
Sobila can in the meantime
Dr.
check
Shobila,
your
you
audio.
have your slides, no? You have your slides with you?
Sobila,
Sir.
can you share your slides?
Yes, ma'am.
You share and start. I don't know what happened to Lakshmi.
Or even without slides, you can better talk and we'll put it later. I think she has
I'm very,
joined.
very sorry. I'm back. I'm really, really
Yeah,
sorry.
yeah, okay, carry on.
I'll just share this screen in a
Yeah,
bit.
yeah.
Sorry. Very, very sorry.
It's
Please
okay, it's
excuse.
okay.
Just a second. I will just start my screen share in a bit. 1 second.
Already started, it's there.
Ma'am, it's just not reflecting on my system. I'll just start it off. Just a second.
Shall I share the slides I have?
Yes, I'm just there. I'm just there. I'm really, really sorry. I'm there. I'm there. Yeah. Please, my apologies for this. So where were we? We are in the treatment stratification.
I think second slide. She was in the second slide.
All right.
Even before this.
Shobila.
Before slide.
This one, right?
Yes, ma'am.
Yeah.
Slide, ma'am.
Yeah.
Yeah,
Very
yeah,
sorry,
start now.
Shobila. Very sorry. You continue.
Start.
The initial management for the HLH includes supportive care mainly, antipyretics, fluids, blood products in case of anemia, thrombocytopenia, nutrition and BP control. The prophylaxis, we need to give pneumocystis cerevisiae and antifungal prophylaxis, and empirical antimicrobial therapy if infections is the cause or the trigger for the HLH. Next slide, ma'am. After the baseline assessment and initial management, we move on to treatment stratification. How to initiate the treatment for these patients? We divide the patients into two groups. Either they are clinically stable or they are acutely ill or deteriorating. If the patient is clinically stable, until the etiological workup is done, we can treat a treatment of triggering condition alone is enough. In infections or rheumatological conditions, when the patient is acutely ill or deteriorating, we have to move on to empirical immunomodulatory therapy or specific treatment initiation if the patient doesn't respond to this empirical immunomodulatory therapy with ongoing etiological workup in both scenarios. So what is this empirical immunomodulatory therapy? If the disease is persistent, severe, or there is worsening inflammation, till the etiology is unclear, empirical therapy can be started. This empirical therapy comprises of glucocorticoids, either prednisolone or methylprednisolone, dexamethasone and high-dose methylprednisolone in pulse doses, or anakinra or IVIG 1 gram per kg per day for a period of 2 days. Next, after identifying the etiology, we move on to the context-specific treatment. Patients who need specific treatment for the HLH, patients with the inherited mutation, HLH due to hematological malignancy, or EBV associated with this malignancy or mutation, and secondary HLH who are acutely ill, not responding to empirical therapy, will be initiated on this HLH-specific treatment therapy. This consists of a total of initial course and a continuation phase. Initial phase consists of 8 weeks and continuation phase extends from week 9 to week 40. So initially, if the patient is genetically verified or familial disease, the ultimate cure is hematopoietic stem cell transplantation. So they have to undergo the initial course as well as the continuation therapy. If the patient has a disease which is persistent, but it is non-familial and non-genetically verified, they also have to undergo initial course in continuation therapy. If the disease is resolved and the disease is non-familial or the non-genetically verified, we can stop the therapy after 8 weeks of the initial course. But if the patient has disease reactivation, and then they also have to undergo continuation therapy for hematopoietic stem cell transplantation. What this specific consists of the first 8 weeks. In the initial 8 weeks, the drugs used are dexamethasone, etoposide, and cyclosporin A. If the patient has CNS involvement, intrathecal therapy is given. So what is the rationale of these drugs used here? This is based on the pathophysiology of the disease. As we all know, this is due to a defective cytotoxic function, which leads to excess immune activation and the cytokine storm. So this dexamethasone, which has a good CNS penetration effect and it has an anti-inflammatory effect, it suppresses the cytokine storm in these patients. Etoposide, which is a topoisomerase 2 inhibitor, it blocks the activated T cells from preventing the release of the cytokine, thus preventing the cytokine storm. This cyclosporin A, which is a calcineurin inhibitor, it blocks the prevents the activation of new T cells, thereby suppressing the disease at its source. Next slide, ma'am. This dexamethasone is initiated in 10 mg per meter square in week 1 and slowly reduced and tapered and discontinued in week 8. And etoposide is given twice weekly for the first 2 weeks and once weekly till week 8. Cyclosporin A is given all days throughout the therapy with the target trough levels of 200 microgram per liter. The difference between this 94 and 2000 HLH protocol is that cyclosporin A is initiated only at week 9 in the 1994 protocol, whereas in 2004 protocol, has been modified that to initiate the cyclosporin A at the week 1 itself for the better treatment of disease and the survival of these patients. Coming on to this intrathecal therapy, in 1994 protocol, only methotrexate is used for intrathecal therapy. In 2004, they have added hydrocortisone to this, and the dose is based on the age wise. So, to whom we have to give this intrathecal therapy? Next slide, ma'am. CNS involvement should be suspected for all patients evaluated for HLH, but the assessment we have to do for the children it is mandatory for children less than 1 year of age and in suspected familial disease and those who have signs or symptoms of the CNS dysfunction. So, how to assess for the CNS involvement? We have to do a CSF evaluation and contrast enhanced MRI brain, which is discussed before. So, empirical or specific therapy can be initiated before the complete workup if the patient is deteriorating. Until we cannot wait for the complete assessment of CNS to be done. This intrathecal therapy has to be continued at least 1 week after the CNS involvement has resolved clinically or in the CSF. Next, after the initial phase of therapy, we move on to the continuation therapy. This phase is mainly to maintain the remission which is achieved in the initial course till the patient undergoes the hematopoietic stem cell transplantation. This also consists of the same 3 drugs, etoposide, dexamethasone and cyclosporin. Etoposide and dexamethasone is given in every alternate week and cyclosporin is given daily till the week 40. Next, what is this reactivation therapy? If the patient has partial remission, then due to a trigger, if he has again developed a HLH, we have to intensification of initial therapy is done. That is, the patient has to undergo the initial course again from the week 1 to attain remission. Next, coming on to the salvage therapy, if the patient has a disease relapse or it is refractory to the specific treatment of the HLH, salvage therapy can be given to the patient. Many trials have found that the combination of this liposomal doxorubicin, etoposide, and dexamethasone with this anti-thymocyte globulin and biologics play a major role in salvage therapy. Stopping therapy, when to stop this therapy? When the patient has a complete resolution of disease and is non-familial, non-genetically verified, we can attain the remission, we can stop the therapy after this. Next slide, ma'am. Coming on to the biologics. Biologics is most commonly used in the relapse or in refractory disease. This biologics is for mainly blocking the cytokine, specifically for the each cytokines. Coming on to the drugs, imapalumab is a monoclonal antibody against interferon gamma. It is most commonly useful in the NLRC4 mutation. Anakinra, which is an interleukin-1 receptor antagonist, it has found mainly useful in the secondary HLH due to the macrophage activation syndrome in rheumatological conditions. Ruxolitinib, which inhibits the signaling of cytokines, has been found to improve this symptoms and cytopenias in this HLH. Tadikinin alpha, which is an interleukin-18 binding protein, is useful in the high interleukin-18 levels condition. Rituximab, which can be given in EBV-associated HLH at a dose of 3.5 mg per meter square weekly. Alemtuzumab, which is an anti-CD52 monoclonal antibody. This alemtuzumab is an alternative to the etoposide when the patient has a severe hepatic dysfunction in the initial course. When etoposide cannot be given, this alemtuzumab can replace its role. Tocilizumab, which is an interleukin-6 antagonist, but its role is very minimized in the pediatric population. This is the whole algorithm. Initially, we should have a baseline assessment. Investigations for etiological workup should be ongoing. The initial management should be given. If the patient is deteriorating, empirical modulator, immunomodulator therapy should be administered. While giving this therapy, we have to assess the patient monitor the patient for inflammation, organ damage, and reassess for the etiological factors. Once the etiology is confirmed, this content-specific treatment is administered. Coming on to the hematopoietic stem cell transplantation, who needs this stem cell transplantation, where the patient has a homozygous or compound heterozygous HLH gene mutation, who has a lack of response to the initial HLH therapy, and those who have central nervous system involvement, and when the underlying cause for the HLH is an hematological malignancy, this hematopoietic stem cell transplantation is the ultimate cure. So what are all the things to be done before this transplantation? We have to do the same pre-therapy testing for these patients, which consist of HLA typing in case of genetic mutations, cardiac function and disease markers, and preparative regimens should be given. It could be reduced intensive conditioning, which includes the drugs such as alemtuzumab or the fludarabine, or a myeloablative regimen, which can be given in higher dose, which consists of drugs etoposide and the busulfan. And graft versus host disease prophylaxis must be initiated just before transplant, which we will be followed 1 week after transplantation. Most commonly include the drug cyclosporin with a short course of the methotrexate. The source for the hematopoietic stem cell transplantation, whether it is in bone marrow, peripheral blood, or umbilical cord blood, has not been specified in any studies. After the hematopoietic stem cell transplantation, we have to monitor monthly for the disease occurrence, and if the patient has a CNS involvement, the CSF analysis should be done once during the first 100 days after hematopoietic stem cell transplantation, even if the patient is asymptomatic also. A donor engraftment on weekly basis should be monitored. So, after the hematopoietic stem cell transplantation, if the patient has an acute flare-up, we can give a short course of the etoposide and dexamethasone trial. If the patient doesn't respond to this and keeps on worsening, retransplantation can also be considered. Prognosis in HLH includes when the patient has a neurological involvement, age of presentation is less than 6 months, and the first presentation, the patient has the highest serum ferritin level, MODS, and EBV associated with this mutation or malignancy, the patient is reported to have poor prognosis. In HLH, patients with familial and non-familial who underwent hematopoietic stem cell transplantation will have same prognosis. When the HLH is due to this rheumatological condition or an isolated EBV infection, the patient will have a good prognosis. So the ultimate recap in this management of HLH is that not all patients need HLH specific treatment. So the initial management and identification of the trigger and the etiology plays a major role. The context specific treatment has to be administered for the patients affected with the HLH. Thank you.
Thank you so much, doctors. But for the little glitch from my side, I think that went really well. The 4 students have presented really well. I think it's time to listen to Janani ma'am, the mentor, the guru for this session, to say a few words. And of course, we have a star highlight, which SBS sir spoke about, a surprise highlight that awaits us too. So over to Janani ma'am.
Yeah, I think all of them did really well. And I mean, that's all I have to say. I don't want to stand in between SBS sir and Ramanan sir. Over to SBS and Ramanan sir.
Janani, your comments so far, if you have anything.
Yeah, I think, they all the 4 of them, they have done their job really well. I think the presentation was very crisp, clear, very minimal slides, and they explained everything in depth. I think people who don't even know about HLH also would have understood the way they explained. That's what I thought. Clarity was really good.
Yeah, I should compliment all 4 of them for the excellent manner in which they discussed a very difficult topic. Welcome, Dr. Ramanan. I hope I'm audible, Dr. Ramanan.
Yeah.
Yes, you are.
Yeah, thank you. Thank you for joining us. And Dr. Ramanan, the whole idea of this program is to take a single theme and sensitize young postgraduates to the recent developments in the field. In fact, I was also selfish in trying to update my knowledge about HLS for quite a few years. I've not seen any case of HLS. I thought I should reorient myself to the recent development. So many new things are happening. That's one of the reasons I suggested to Dr. Janani, and she has rightly chosen 4 postgraduates, brilliant postgraduates who have done a very good job. Before I question Dr. Ramanan, trying to get more information about recent developments. Dr. Ramanan, we had a review of the following areas. First, there was a nice introductory lecture on the etiology and the history of HLH starting from 1939 to 2004, diagnostic criteria to recent developments, all monoclonal antibodies, etc. And there were quite a few slides on the genetics of
Mutation.
HLH. Then there is a very good presentation on the clinical features. And in the diagnosis, it was interesting to see the
Tier 3 and Tier
intent in
4.
the HLH, particularly the CNS HLH, often very difficult to diagnose. And then, of course, treatment including epapalumab, which we have never used. I don't know, Dr. Janani, I don't know if she has used it.
I don't know, sir.
I have not used so far. And that is what was going on for the last 45 minutes. Let me ask Professor Ramanan, from the first case of HLH that you had seen, the last case you had seen in Bristol, how has the whole spectrum changed, or the spectrum is same, but your approach has changed? That's my first question.
Sure. Thank you very much. And my apologies that I missed what seems to be been amazing presentations. I might have learned a lot as well. So
we will share the slides with you.
Sure, thank you. I think what has changed is awareness, really. And I think there's got to be a discrimination between our knowledge and awareness. I don't think the condition itself has changed much. Our understanding has significantly evolved. Probably 22 years I've been in Bristol as a consultant. Initially, the diagnosis was predominantly made in children who present in the first year of life with what looks like sepsis. So they'll have cytopenia and coagulopathy. A very straightforward primary HLH. Our understanding in the last 2 decades has evolved to know that you can have secondary HLH in the context of infections, in the context of inherited immune disorders, and in the context of rheumatological disease. Rheumatological diseases we probably knew a bit, although there was nomenclature issues. And I think a simple view would be that all of these patients will have underlying genetic defects. So either you would have primary defects in probably what has been touched on, like perforin mutations and so on. And some of them present in the first year of life. But some of these patients can present in the second decade of life, even in the third decade of life, well recognized, the same mutation. So what we now call phenotype, genotype variability is increasingly recognized. In the same family, you will have one child with the mutation presenting in the first year of life, another child presenting at 7 years of life. And then even in the so-called secondary HLH patients, and EBV is the best example, EBV is a fairly common infection. Why is it that a few people get HLH, whereas 95% or 99% just get a mild viral illness and recover? And probably they have, if not a mutation, polymorphisms in these genes. And we've done some work without wanting to go into the detail. And these polymorphisms are such that when in a steady state, the individual is fine. But all they need is a second hit with EBV. And then these polymorphisms create a situation which is similar to having an underlying mutation. So the understanding, in answer to your question, is more awareness. And awareness then creates greater ability to consider the diagnosis, make the diagnosis, and then institute appropriate therapy.
And also availability of genetic tests.
Yeah, even though that said...
Easier availability, yeah.
Yes, but this is one condition where in the acute context, you're not going to have that information.
Yeah,
so
that's true.
If you take the criteria, we did an audit of the 8 large children's hospitals in UK, and we showed that what we did was looked at all ferritins about 10,000 between 2007 to 2015. And we looked at the notes of all these children, the whole of England, and we found that in 35% of these patients, the diagnosis was not considered. And about a third of the children with ferritin of more than 10,000 died, and many of them. So today, if you get a child come in with cytopenia, coagulopathy, and a high ferritin, it will probably take 4 to 6 weeks for you to get the exome sequencing done. You probably won't get the soluble CD25. You probably may not be able to marrow if the child is very unwell. So even though we have made a lot of diagnostic advances, much of it is not accessible for a lot of people in the acute setting at a time when you have to make the decisions, because what if the exome sequencing comes in 6 weeks' time and it's too late for you to have a meaningful? So you're still left with the same bloods that you had 20 years ago, which is a full blood count, a serum ferritin, a clotting profile, and a high index of suspicion.
Correct. Agreed.
Okay. Now, in fact, I was going through some recent articles. The most difficult one to diagnose amongst the different varieties of HLH for the clinician, I believe, is the CNS HLH.
It mimics other conditions.
What's your take on it? Because I'll tell you, I remember a child way back about 15 years back. I think we even discussed this case with you, where a child appeared to have straightforward viral meningoencephalitis for which we could not identify the cause. And initially, the counts were normal. Later, there was bicytopenia. Initially, ferritin was normal. Later, the ferritin rose, and we picked up very late. Of course, the child is alive now with some sequelae of CNS, with behavior disorders and seizures. Now, what is your take on early diagnosis of CNS HLH? And what's your experience?
Yeah, well, it's a very difficult question to answer, and our experience has been both good and bad. We have lost children from CNS HLH where the systemic manifestations were very vague. The bloods were completely normal, and some of these patients, unfortunately, the diagnosis was made at autopsy. So not a situation you want to be in. I won't dwell too much on CNS HLH, because if you have a child who's systemically unwell, you have cytopenia and you have coagulopathy, you can consider, and you should consider HLH. But if you have somebody who's got isolated CNS symptoms and a completely normal blood profile, it's a very difficult diagnosis to make. Now, I just caught the tail end of the last presentation, and Jan Inge Henter, who is a very close friend, and in fact, I visited him at Karolinska, and he's been to us. He would share the same experience. Isolated CNS HLH is almost an impossible diagnosis to make if you do not have the systemic manifestations. You can have a high index of suspicion, but if you have nothing except symptoms and the peripheral bloods are normal, it makes it very hard. Now, coming to management, then if you have viral meningoencephalitis and you're not winning, one might make the case for giving intravenous immunoglobulin in such settings, hoping that if this was some of the disease process like primary CNS HLH. But otherwise, I don't think I have any smart answers. You can't really make a diagnosis of primary CNS HLH that easily, because imaging isn't going to help, CSF isn't going to help. So
going to mimic most of the other conditions.
Exactly. And unless you have the systemic manifestations come, it's a very difficult diagnosis. But I don't think we should go away from this session focusing on probably what is 1% of all HLH, which is okay to not necessarily pick up. The problem is, and as you know from the 2007 paper that was done in Child Trust, the key message for postgraduates and practitioners should be that secondary HLH can be seen in patients with known bacterial infections, with viral infections like dengue, with leishmania, which I know is much more common in India than in other parts of the world, and TB. So having a known bacterial, viral, or a mycobacterial, or for that matter, even a parasitic trigger is not an exclusion. If appropriate antibacterial, antiviral therapy isn't working, you're getting progressive cytopenia and elevated ferritin,
Consider
then you
HLH.
must have a low threshold for treating for HLH. I think that should be the take-home message.
Correct.
And the next question is on ferritin, Dr. Ramanan. I know a few colleagues of mine, a few intensivists I know, who for straightforward cases of, say, dengue, typhoid, or scrub typhus, they do ferritin, and even if the levels are something like 1,000, 2,000,
they start
they
IVIG.
give IVIG and they give steroids. What's your comment on it?
So let's take ferritin. It's an incredibly helpful biomarker. The good things about it is it's cheap, it's universally available, which makes it incredibly attractive. Now, the first criticism of an elevated ferritin is an acute phase reactant. So you're going to say, can it go up in sepsis and so on? Now, lots of studies have shown ferritin of about anywhere from 500 to 1,000. You can't really hang your hat. It's something that can go up in lots of inflammatory conditions. Multiple studies have shown that 5,000, we've done, including our own work, receiver operating characteristics, 5,000 is highly suggestive of HLH. Okay, so we've published an algorithm, which if possible, I'll share in a minute, but for general pediatricians, which is if you have a ferritin of more than 10,000, you're almost always dealing with an HLH condition. Whether it's primary or secondary is a matter for later. For now, you've got to treat them for HLH. If you've got something between 5 and 10,000, I would say the same. It's incredibly likely that you're dealing with HLH. And you probably, if you haven't done things like fibrinogen, which people don't usually do, you can do that. If it's less than 1,000, it's unlikely you're dealing with a primary or a secondary HLH. Yeah. So again, the key message is in any patient who comes in with sepsis, along with full blood count, urea, electrolytes, liver, and renal function, serum ferritin is a valuable thing. So we've incorporated that in our intensive care unit. And I think it's right that your intensivists are doing. The crucial question comes when you intervene. So if you have something between 1,000 to 3,000 and the patient's responding and they're getting better with supportive care, you can afford to wait and watch. IVIG is an easy one to use apart from its slight cost because it doesn't interfere with any disease process such as malignancy. So that's fine. But if you're above 5,000, I think you can very comfortably say you're dealing with an HLH, whether primary or secondary, and it doesn't matter. We've published this as an algorithm. If possible, while you're asking questions, I'll pull it up if I can.
Okay, I think that's a very good message to general pediatricians like me. If the ferritin levels are more than 10,000, HLH is very much likely. 5,000 is a red flag. And anything
less than 5,000, we can wait.
5,000, anything less than 1,000, HLH is unlikely. Is that right, Ram?
Yeah, very much. So I'm going to try and see if I can, in a minute, I can share my screen and I will show you something if it's okay. If you've got a few minutes and if I've not taken too much of your time. Yeah.
Please go ahead.
Lakshmi, can you make Sar as a co-host for him?
Yeah. Okay. So this is just to give you, even in UK, what happens. So I'll just skip this. So we as I said, this was a 3-year period, and we looked at ferritins of more than 10,000. Okay. Now, UK is very similar to India in that we can only do 5 of the 8 things which everybody has access to, which is the clinical and the simple biochemical. These 3 tests are never usually available to most people in the acute setting, which is NK cell function, soluble IL-2 receptor, and tissue hemophagocytosis. So we said, if anyone's got 4 of the 5 in a real world, that's HLH, along with the ferritin of more than 10,000. And what I'm showing to you here is in a 3-year period across England, we identified 94 children. Okay. Of course, about 10% had systemic JIA. Half of them were admitted to an intensive care unit. And what you see here, this is children with ferritin of more than 10,000 who meet about 5 or 4 of the criteria. The very complex tests are never usually available. Only half of the children with a ferritin of more than 10,000 were diagnosed as HLH. In 1/3, according to the notes, the diagnosis was not even considered. Is this significant? Yes. 33% of children with ferritin of more than 10,000 die. That is 1 in 3 children with a ferritin of more than 10,000 die. And about 1 in 5 of these children, the diagnosis was not considered. If the diagnosis is not considered, then you're unlikely to be able to treat for the condition. So I'm going to show you the picture we do, which I'll just see if so we published this. So this is what I would suggest you use. So in any child with fever, cytopenia, query, sepsis, you check ferritin. Of course, it would be nice if you can check IL-2 receptor and so on. I can, and we can get it in real time. But I know for a lot of people in the settings you practice, soluble IL-2 receptor, NK cell function may not be available at all or may not be available in real time. So ferritin is a useful marker, then fibrinogen, LDH, and then you can stratify. Now, these days, in the last 10 years, data is showing 10,000 is probably too high. Even 5,000 is a good enough cut. And there's good data with stats using receiver operating characteristics showing 5,000 is as sensitive as 10,000. That's all I wanted to share. So,
sir, is it true that in MAS, the ferritin can go very high? Because we had one boy with SOJIA with MAS, where the ferritin went up to 75,000. Is it true that MAS, the ferritin goes up more than HLH?
Yeah, MAS is a form of secondary HLH, and yes, I've seen ferritin of 210,000 in those. But really, in the rheumatological conditions, yes, the ferritin can be much higher. But the principle remains the same. Any ferritin above 5,000, you're dealing with a form of HLH. In a known rheumatological patient, it might be MAS. In an infection patient, it might be a secondary HLH. In somebody who's young and presenting like this, then you may have to consider the prospect of primary HLH. But the concept of primary HLH no longer has to be only those who present in the first 2 years of life. With easy availability of exome sequencing, you probably have to consider it in all along the way, even up children who are as old as 7 or 8.
Is IL-18 available in UK, sir?
Yes, in certain centers, but a poor man's IL-18 is ferritin.
Okay.
Just as a poor man's IL-6 is CRP, a poor man's IL-18 would be ferritin. Now, that's a huge extrapolation, but 90% of the patients who have elevated IL-18 will have elevated ferritin. There are a few instances, and for those, perhaps your PGs may have already highlighted this. There are other fancy tests we can use, such as CXCL9 and so on. But the truth be said, it's very hard to access this in many places. Yes, I can access it if I want, but even for me, it will probably take 48 hours from sending the result.
I don't think we should wait when the child is sick. Yeah.
Exactly. And I think one of the issues with IL-18 and CXCL9, for those who are very interested in this sort of fancy test, is they are not easily validated assays, which means if some company or some lab is starting to offer them, you have to be careful in how you interpret their values, because unlike ferritin or CRP, they are not easy assays. They are not universally validated assays. They are still research lab assays.
Very rarely done also, yeah.
Correct. And so the research lab assays always suffer from a lot of lab error. So my advice would be not to go for doing CXCL9 and IL-18 unless you're working in a tertiary center with an academic interest and you've got a lab which you can personally vouch for.
Okay, the next question to you is regarding the treatment. Okay, you diagnose HLH and you said the IVIG is a safe drug, whether it works or not, you give. And of course, you had already mentioned that any child who's having a clinical picture consistent with HLH, we should straight away send the exome sequencing initially itself, because it's going to take 4 weeks or 6 weeks for you to get the report. That's one message you gave. And that should be done preferably before giving blood transfusion or IVIG. Is that right?
Yes, although exome shouldn't usually be massively affected. And I think exome is only if it's affordable. I know that for some it may not be affordable. I think that shouldn't take away the issues. And we always, to be fair, even though we say that, I get consulted on 1 or 2 HLHs a week. We don't always launch into doing exome sequencing in all of them straight away. You can do that later in the course. Yeah, it can wait for a bit later as well.
Okay, that's one. Second, so the other question to you, Dr. Ramanan, I have asked you several times the same question. I'm repeating it. Steroids. You saw in the PG's presentation, Dr. Janani,
Yeah.
dexamethasone, methylprednisolone, pulse methylprednisolone.
Correct.
Ramanan, how do you decide whether you should give dexamethasone or 1 to 2 milligrams of methylprednisolone or prednisolone, or pulse methylprednisolone 15 to 30 milligram per kg? This is a very confusing
Always,
question, confusing scenario which general pediatricians like me face frequently.
So it's interesting. It's actually not that complicated, but it's more due to evolution of things. So, for example, forgive the analogy, but it's like in the south we might prefer rice, in the north they may prefer chapati. So it's hematologists like dexamethasone, rheumatologists like IV methylprednisolone. The hematology excuse for giving dexamethasone will be they'll say it's got better CNS penetration, and that most of these patients will have subclinical. But there is no no solid reason not to give methylprednisolone because it has also got good penetration. So that isn't the issue really. And I don't think it's a problem if you want to give dexamethasone or prednisolone. I personally prefer prednisolone, methylprednisolone. So I will tell you what dose now. So I can only speak of those two. If the child is unwell, intubated, ventilated, or significantly unwell, you've got serious coagulopathy, a ferritin of 15,000, platelets, which are 10, and hemoglobin, which is 7. I think giving methylprednisolone, anything between 10 to 30 milligrams per kilogram is my preference. I generally give 30 milligrams per kilogram, max 1 gram for 3 days. Now, if you're going to say, I only want to give 10, I won't have a problem. Steroids work in 2 mechanisms, and we've always asked, whenever we discuss this. So high-dose steroids, which is between 10 to 30 milligrams, work in a non-genomic mechanism, and they tend to work very quickly. When you give 1 to 2 milligrams, they work primarily by genomic mechanisms, so which is through downregulation of the pro-inflammatory cytokines and the upregulation of anti-inflammatory
takes time
cytokines,
also, yeah.
Which takes time. But so in an ill patient, give 10 to 30 milligrams per kilogram, max 1 gram. If your patient is not very unwell and you think the bloods are abnormal, but the child is not in oxygen, is not in intensive care, and not needing much supportive care, then you may be okay. But in almost all HLH settings, I've always given pulse methylprednisolone. If you made a label of primary HLH and you're following the HLH 2004 protocol, because oncology is always protocol-based, then you will go with dexamethasone. And as highlighted in the tail end of the last talk that I caught, you will go with the HLH 2004 protocol, which will be etoposide, intrathecal methotrexate, dexamethasone. In the setting of a protocol, it's easier because it's easier for everyone to follow. But if I'm treating a secondary HLH, I always give methylprednisolone.
Okay.
Got it.
Okay. The last question I wanted to ask you, if you review the literature on HLH in India, most of the reports show predominance of secondary HLH over primary HLH. It's not the same in the West. What's your comment on it?
We have more tropical infections. That's the answer.
Yeah, but there's also an observational bias. A lot of the primary HLHs may die without getting their diagnosis made.
Get missed, yeah.
So their death certificate will read sepsis, query, cause, death, DIC. So I would actually say the opposite is true. There is probably more primary HLH in India or in the South Asia than elsewhere. Because if you go back in time, the first paper on perforin mutation was published in Science, which was done in Bradford in England, which has a huge Pakistani community where consanguinity is very high. So in parts of the world where consanguinity is high is where several of these mutations have come up. For example, the syntaxin mutation has not been recognized that much outside the Turkish cohort. So my educated guess would be there is as much primary HLH as secondary HLH. And of course, Dr. Janani's point's right about secondary HLH. I think you have as much primary, if not more primary HLH, which is undiagnosed. And then you have a huge proportion of secondary HLH, which is increasingly recognized and picked up and in the context of dengue and other tropical infections. But primary is there. They probably, if you were
Go
to do
undiagnosed
exome
mostly.
sequencing, yeah, absolutely.
I mean, by the
think,
time they come to a tertiary center, they're almost gone.
Yes, and not always in all the patients who sadly succumb from sepsis would you do exome sequencing or autopsy to look at splenic or. So one of the things was in the Swedish cohort, they showed that when they looked at autopsies of 33 children who died of HLH, marrow yield is the least, 33%. The best organ to biopsy, which is the organ we least biopsy.
That's why the criteria says marrow can be negative.
Yeah, so spleen is incredibly good, but at autopsy. So the point that I'm making, therefore, is index of suspicion should be always the key message. And primary is common, and probably secondary is equally common and being diagnosed more.
My last question to you. A general pediatrician treats a confirmed dengue or enteric fever with features consistent with hemophagocytic lymphohistiocytosis, but the child recovers completely. Should he do genetic tests for primary HLH or not? Difficult.
No, easy. Yeah, I don't think I'm going to be brave in saying no, because you see the situation so often that you don't want every postgraduate and general pediatrician going around ordering exome sequencing. I think if you see a second episode with another infection where they become again critically unwell, that's when you should consider. With the first episode, I think it's perfectly reasonable if they are treated and recover to not do anything.
Okay. Any final comments from Professor Ramanan?
No, I think there were a few drugs which were mentioned, which is, and I've got experience of using all of those, but emapalumab is an incredibly expensive drug. So I don't see it being universally available, even if it becomes accessible because of cost considerations. Ruxolitinib is a JAK1/2 inhibitor, which is the same as baricitinib, except it's not renally excreted. That has the prospect of being an effective drug, and it's a small molecule, which means when the patent goes, it will be the same cost as making paracetamol, so it will become cheap. And that probably in the next 5 years or so may offer prospect of being an effective drug after IVIG and steroids, which is accessible to a huge proportion of the population. But you must remember that in sepsis populations, when you use JAK1/2 blocker like ruxolitinib, the risk of herpes infections is high. So if you suspect herpes simplex, then it's probably not the drug of choice. So the take-home message will be for all sepsis patients or anybody who you're treating for an infection is not getting better, check serum ferritin. If the ferritin is above 5,000, consider the diagnosis of HLH and speak to someone or treat with IVIG or steroids. Other drugs which might become more accessible might be JAK1/2 inhibitors. And of course, if you suspect primary HLH, then you have to go down the HLH 2004 protocol. The disadvantage of the HLH 2004 protocol and stem cell transplant is even in the West, the mortality is 50%. And in your context with PP16, etoposide, intrathecal methotrexate, secondary infections might be a huge problem. You have to keep them alive enough to get them for cross-match and
they become more immunosuppressed.
And transplant in these populations is not as easy as doing an ALL transplant. The mortality for transplants in this population is much higher.
Very high.
And thanks for asking me to join.
Okay, thank you, Professor Ramanan, for joining us and enlightening us on the recent aspects. Over to Dr. Janani.
Yeah, I think it was complete with Dr. Ramanan's comments. And I think SBS sir asked him the right questions. So we got answers for all our queries. I think it was a wonderful session. Thanks again to Sudhakar for the thought and Dr. SBS for his final take-home points with Dr. Ramanan's inputs. And thanks to all the presenters who did a wonderful job. We'll share the slides with you, sir. They've done a wonderful job. We'll share the slides, and I should thank Lakshmi for coordinating very well.
Madam, in this time I want to thank all the professors HOD who has sent the students, Dr. Alok Ravi sir, for Dr. Darshini from IC Chennai, and Dr. Nandini Kupaswamy Madam for Dr. Dr. Shobila from Madurai, and Dr. Bhaskar from Manakala Vinayakaran. So, Dr. Srinidhi, we have to thank for accepting our invite. And Janni Madam, we're really grateful for the effort you had put for this actually. And
It was my
of course,
pleasure.
yeah.
Like
And
SBS sir, I
SBS
also
sir,
learned a lot.
yeah, really, madam. I
Gave me
also
an opportunity
started.
to read and yeah.
Yeah, SPS sir, your guidance is really invaluable. You come out with a lot of new ideas. We can come to you in the very blank and you'll give a lot of ideas to us and make us to feel again a student. In 2003, I think, 2004, we attended his classes as a student. Still, we are feeling the same experience. We are having the same experience. You are giving new points for us. And Dr. Ramanan sir, thank you for sharing your expertise and experience. This is the catchy thing in this program actually. Finally,
Very nice.
sharing the experience from the Western, from an Indian, by an Indian, from the Western. So you know what is the happening in India. And rightly you said British, yes, it is like in India. And still
Correct.
they are also have a lot of limitation, but still how they are managing. Yes, sir, at the final, I thank you so much for doing all the things for us. You are spending a lot of time for us, doing a lot of work for us, and your questions are really exciting for us. Actually, we started learning more from the questions itself.
Correct.
And thank you, Dr. Lakshmi, for coordinating the whole things.
Yeah,
Thank
I
you,
think
sir.
before finishing, I think we should just have one word from each of the presenters.
Yeah, yes, madam. I forgot.
How they felt, starting from Maheshwari. The presenters, can you unmute and just tell one word?
What is your
And also-
experience and how you felt?
Please turn on your video so we can all see the budding speakers too.
Yeah.
So
Turn
it
on
was
the
a very
video.
difficult topic,
Not in that
actually.
order. Anyone can talk.
Yeah,
Whoever is there.
whoever is here.
Darshini, I can see Darshini. And Darshini, you can put your video on and just, yeah. Yeah. So we also got a chance to see you. Okay, good. Yeah. How did you feel the presentation and everything?
Overall, it was a very nice experience, and we spent so much time on reading about it.
Okay.
And it was very good.
You did clinical, Ella? Clinical features you did.
Yes,
Yeah? Good, good. Very well done. Very well done. You're from ICH.
yes,
Very well done.
thank you.
The other one, where are the others? Shobila, they all left, is it? I think if they're not, they don't bother.
Good
Yeah.
No,
Srinidhi
they're
is
here.
there. Yeah.
They're
Yes,
here.
ma'am. Good evening, ma'am. Thank you so much, ma'am. I thank Janani ma'am for guiding us throughout this session, and ma'am was whenever we faced any issues, like we didn't have any access to articles, ma'am just send the articles, and it was a good learning experience for us, especially on the recent updates from various national and international journals. And also she gave us some how to present it in a very crisp manner. And also I thank Lakshmi ma'am for helping us compiling the slides.
You did diagnosis, no, Srinidhi?
Yes, ma'am.
Yeah, you did a very good job. Yeah, good.
Thank you, ma'am.
Maheshwari?
Yes, ma'am. I have learned a lot, ma'am. Especially we have learned a lot from the surprise Ramanan sir's joining. And by preparing, we have learned the whole HLH device updates. Yes, ma'am. Thank you, ma'am, for
Good,
the
good.
opportunity.
Shobila is there, huh?
Thank you so much, ma'am. We have learned a lot about the HLH. Thank you for guiding us, ma'am.
Yeah, all of you did well, and congratulations and good luck for your future.
Yes.
Thanks
Thank you
again
so
to
much.
SBS sir. It was SBS sir's idea to choose HLH so that we all got updated.
Yeah, yes,
So,
madam.
thank you,
I
sir.
started reading Nelson, SDG guidelines, and downloaded so many
Yeah,
things.
I mean, in fact, I told sir we'll do UTA. Then sir told UTA, everyone knows, don't bother. Let's do HLH. I said, okay, sir, we'll learn something new.
Yeah.
Thank you, sir, for making us go through all the newer articles and get ourselves updated.
Thank you.
Thank you again
sir.
for inviting
Thank you,
Ramanan sir also. Good
Thank
night,
you,
all
sir.
of you.
Thank
Thank you, sir. Thank you,
Bye.
every one
Yes,
of you.
thank you.
Sudhakar, congratulations on your first action plan.
Thank you, madam.
Very well done. Very well done. And I'm happy that you did not have this good evening felicitations.
Yes.
That is the highlight of this
I
program.
fall
We
in
just
line with
started off.
SPSR and you know this rituals.
Very good. Very good. I'm so glad about that.
Next program, there should be no photos of ours. Thank you.
Yeah. The flyers should not have any photos. Yeah.
Done, sir. Done, sir.
Thank you.
First time, sir, you did, sir. Okay, sir.
Thank you. Thank you.
Okay. Thank
Okay,
you.
sir.
Thank
Thank
you.
you.
Thank you all. Bye. Bye. Bye, Lakshmi.
Thank you, everyone. So on behalf of Team CCB, our hearts go out to the Bhishma Pitama, of course, SBS sir, and Janani ma'am, again, our very dear guru. Thanks to the postgraduates and their department heads for suggesting their names. And thanks to all the participants who joined us today. Maybe, on a lighter vein, let's end up. So whenever we have a child in the PICU with sepsis, septic shock, and hyperferritinemia, depending on the consultation that you ask for, the diagnosis will be different. An intensivist will say MODS, a rheumatologist will say MAS, and a hemato-oncologist will say HLH. But today, after this presentation, I think we now know what the consensus is, when we should have clinical suspicion, what our diagnostic tiers are, and trigger identification. So I guess we're all a lot wiser. So until we meet next
Use
time,
your
this is
clinical
Team
senses
CCB
before calling
signing
them.
off. Yes.
Use your clinical senses before calling them. Yeah.
Absolutely.
Yes.
So I think that should be the take-home message.
Yeah.
So until we meet next time, this is Team CCB signing off. Good night.
Bye. Good
Good
night.
night. Good night.
Bye. Thank you.